I am Dr. Vineeth Vijayan, Pediatric Allergist and Asthma Specialist. Today we will be discussing on the recent updates in GINA guidelines. GINA guidelines 2026 has lot many updates. It updates the entire patient pathway, relying on the latest peer-reviewed clinical trials and observational data. This update is driven by two specific clinical shifts. First, the acute management protocol adopts a highly conservative approach. The guideline restricts interventions that frequently cause medication-induced harm during the exacerbations. Second, the anti-inflammatory relievers are now integrated across all long-term maintenance tracks. The goal is to treat the underlying airway inflammation every time a patient reaches for an inhaler. Implementing these protocols require adapting to vastly diverse healthcare system. To see how these guidelines operate in practice, we need to trace the patient's chronological journey, starting from acute triage and moving to the long-term control. The 2026 updates form a unified strategy by targeting airway inflammation at every clinical touchpoint. The providers can lower the frequency of severe exacerbation and reduce overall patient mortality by treating airway inflammation at every clinical touchpoints. The initial triage point is defined by a newly structured layout. The protocol splits from a central acute presentation node into four pathways. The flowcharts are first divided by patient age, then again divided based on the clinical setting, like primary care versus emergency department or acute care environments. If a patient presents with features of acute asthma and anaphylaxis, the standard flowchart is overwritten. The protocol mandates the administration of IM or intranasal epinephrine first before any bronchodilators are deployed. For children under 17 years, assessing the severity of the presentation now requires the use of a validated objective clinical score such as Pediatric Respiratory Assessment Measure or PRAM score. New conservative limits are also there for supplemental oxygen during an acute attack. Oxygen is not recommended unless saturation falls below 92%. This change directly addresses a common clinical error, the high probability of SABA toxicity resulting from aggressive overtreatment. Excessive SABA administration frequently leads to a specific metabolic consequence like SABA-induced lactic acidosis. The primary symptom itself is a severe compensatory hyperventilation. This rapid breathing is routinely misinterpreted as worsening of the asthma symptom, prompting providers to administer more SABA. This creates a vicious cycle of iatrogenic harm. To safely deliver lower, precise bronchodilator doses, patients typically use a pressurized meter dose inhaler with a spacer. For inhalers formulated as suspension, physically shaking the canister immediately before every actuation is required to prevent accidental ultra high or low dose errors. The protocol also introduced a major therapeutic addition, that is, ICS formoterol is now on an approved frontline alternative to inhaled SABAs for mild exacerbation. By pairing conservative bronchodilator limits with rigorous mechanical technique, providers break the toxicity spiral and stabilize the patient safely. Once the patient is stabilized and discharged, the clinical focus shifts to long-term maintenance strategies. The GINA guidelines separate maintenance care into dual pathway system, track 1 and track 2 algorithm. Track 1, utilizing ICS formoterol for both maintenance and relief, remains the globally preferred approach for adults and adolescents due to the simplicity of a single inhaler regimen. But if you are going for other inhaler other than track 1, it has undergone a structural update at its entry level stage. Step 1 now completely removes SABA only relievers. Replacing it with a combination ICS SABA is required. This update is driven directly based on the clinical evidence from the Batura trial, which showed nearly 50% reduction in the severe asthma exacerbation when patient used ICS SABA compared to a SABA only reliever. But this regimen does introduce a new educational burden because the patient has to carry two separate inhalers, one for maintenance and one for relief, throughout step 2 to step 5. Across both tracks, previous language dictating a maximum daily dose limit for reliever inhalers has been entirely removed. In this place, it's a new 24-hour review prompt. Patients are now strictly instructed to seek urgent medical care if they exceed a specific inhalation count within a single day. Standardizing anti-inflammatory agents in every single reliever puff requires that airway inflammation is treated the moment symptoms arise. The, the updates across the acute triage and long-term maintenance serves a unified clinical endpoint, that is oral corticosteroid stewardship. The stewardship relies on three pillars. First is optimize inhaled therapy to prevent the need for systemic steroids. Utilize targeted biologic therapies to bypass corticosteroid reliance and avoid maintenance oral corticosteroids treatment except as an absolute last resort. Beyond individual patient outcome, the stewardship intersects with a secondary global priority, addressing the environmental impact of traditional inhaler propellants. The propellants the guidelines support a deliberate transition away from high carbon PMDIs towards a dry powder alternatives wherever possible. However, this environmental mandate must be carefully balanced against the absolute necessity of maintaining uninterrupted essential medicine supplies in low income countries. The strategy of 2026 GINA guidelines connects every phase of care. By mitigating medication induced harm and reducing the environmental impact, the providers can deliver optimal evidence based asthma control across the globe. Thank you.